I'm Brian Blair. I'm an orthopedic surgeon, and I'm fellowship trained in sports medicine. And I've given talks before on joint preservation, but my true love, as they say, is the shoulder. So my fellowship training was very heavily emphasized on shoulder injuries, simple as well as to the very nasty shoulder injuries. So the shoulder is a very complex, weird joint, right? I think before I went to medical school and before I did orthopedic residency, it was one of those joints that I didn't know a lot about and was very interested in the more I learned about it. It's a weird, complex, complicated joint. So you have the bony anatomy, right? Your humerus, the scapula, your collarbone, and then you have, on top of that, your shoulder doesn't sit in a socket like some joints, right? Like your hip sits in a socket. Your shoulder doesn't. And so it's surrounded by all this tissue, soft tissue that surrounds the shoulder as the capsule that holds it into place, right? And then this is what that joint capsule looks like. This is if we removed your arm and we're looking straight onto your shoulder. This is the socket part of your shoulder. And you can see all this soft tissue that surrounds your shoulder is what holds it into place. And then the cartilage is on the surface of the socket, which is called the glenoid. And then you have these muscles that surround that capsule. We've all heard of the rotator cuff muscles. Those are 4 muscles. The common term we use is sits. One of them is called the supraspinatus. It's the one up top. That's the one people tear most commonly. When people say, oh, I have a rotator cuff tear, usually it's that muscle up top, the supraspinatus. And then there's one in the front called your subscapularis muscle. That's the one that goes in the front of your shoulder. And the back, there's 2 muscles, your teres minor and your infraspinatus, and they help you move your arm out. So each of those muscles has a certain function of how you move your arm up and down, side to side, and they help with strength and help move your shoulder. And so there's another layer on top of that. And then also around your shoulder, you have all these arteries and nerves that supply these different muscles. The nerves are like the electricity. The arteries supply the blood flow and the nutrients to the muscle and bone and to the tendon to help with healing. So there's all this stuff, arteries and nerves, that we have to think of that can get injured, that can cause shoulder problems. Or when you have rotator cuff tears, you can it kinks nerves and kinks vessels, and there's all different things that can happen around your shoulder. This is a cadaver specimen of your shoulder. There's the head of the humerus, and all that shiny stuff is your cartilage, right? And then the socket part is here up top, and all that shiny stuff is cartilage. And this is just a picture showing you cartilage. And so arthritis is when you lose that shiny cartilage. When it falls off, breaks off, gets damaged, gets injured, that's what arthritis looks like. This is nice and smooth and white, so that's normal. So what causes shoulder pain? There's a lot of things that cause shoulder pain. You know, when someone comes to the office and says, my shoulder hurts, usually, you know, we have to localize where does the pain come from? Because you've got your neck right above your shoulder, right? And your neck pain can cause shoulder pain, and shoulder pain can cause neck pain. So we always kind of start with the neck and work our way down. But there's a lot of different things that cause shoulder pain, right? So when we do surgery on people, there's all kinds of different things. That tissue that surrounds the socket of your shoulder here, this tissue is called the labrum. So it's a lining of tissue around there. And you can see that little bicep tendon. It inserts on the top of your socket and forms a circular band of tissue that surrounds your shoulder called your labrum. A slap tear is what we refer to as the top part of that labrum where that bicep anchor attaches. Where'd it go? Right up here. See that little long tendon? That's your bicep. Where it attaches, it can get torn at the point of its attachment. Rotator cuff tear. So all those muscles I just talked about, you can tear those. You can tear them by falling. You can tear them by picking up something heavy. You can tear them by doing nothing at all, just moving your arm over time, right? Back and forth motion can cause a bone spur to rub on your rotator cuff, and it'll thin it out, and eventually it tears. You may not even know it. Instability refers to people who dislocate their joint, right? Most, you know, when I refer to shoulder instability, usually that's a disease of my high school basketball player, my high school football player. usually they have a problem with the inherent, remember the shoulder doesn't sit in a socket, it's all that soft tissue that surrounds your shoulder. Some of us are born and our tissues are more lax. We're just, you see those people that are super flexible, right? They can take their arm and do all kinds of positions. That's just the way people are built. That makes people more prone to dislocating their joints, especially very common in the shoulder. Now you can fall and land on your shoulder and dislocate your shoulder too. Anyone can do that. But that's what we refer to as instability, is when that shoulder joint moves out of place, whether from an injury or just being the way you're born. Bursitis is one of the most common things that I see. Usually the patients that come in with this are people that have had it 2 or 3 months. It can be brought on by nothing. It can be brought on by lifting something you didn't even think of, starting a lawnmower, doing anything. Sleep position, a lot of people sleep with their arm over their head. It's very common. When you raise your arm over your head, there's a bone on the top of your shoulder. It's in this space up here, right above your shoulder, below this bone on top of your shoulder, between that and your humerus. That's where the bursa lies. And its function in life is to help things glide more smoothly over each other. So as you move your shoulder, it helps things glide. Well, a lot of the times that bursal tissue gets inflamed and irritated and red. You got to think of it as red inflamed tissue. And so that's a common thing that we see. And then cartilage problems that I talked about, the cartilage surface, whether it be arthritis or injury from trauma, you can get cartilage problems too. So most shoulder things we treat non-surgically. A lot of the times, as with any of these things, we start simple, usually with injections, oral anti-inflammatory medications. But I'm a big proponent of using injections in the shoulder. It gives me a lot of information, probably more information than any test I can do, any MRI that I can do. The beautiful thing about the shoulder is a lot of the times we can inject your shoulder in different areas, and if we can make the pain go away even temporarily, it helps me determine what your pathology is. So usually, most of the times we treat these things with injections, physical therapy, and that does the trick. Especially for things like bursitis, things like that. For rotator cuff tears, it's a different story. Once that tendon tears off the bone, it won't heal itself. And a lot of the times when people have rotator cuff tears, they complain of pain, but they also complain of a lot of weakness. And so that muscle's not attached to the bone anymore, so you can't lift your shoulder up anymore. One, that causes pain, and then people complain I'm weak. Those things we like to try to fix, because if you ignore it, that tendon doesn't heal itself, and then it can have long-term consequences too. But this is just a picture of when we do surgery on people. The way I do it, most people lay on their side, and then this is the arm. It's hooked up in some traction device. And then these instruments we make these little holes with the scope. So everything we do, all of the stuff I do arthroscopically, especially with rotator cuff tears and instability and all that stuff. Now shoulder replacements and fracture care and all that, we don't do arthroscopically, but most everything else we can do through the scope. So this is kind of what that setup looks like in the operating room. So rotator cuff tears. So again, we talked about those 4 muscles, and this is just a picture of kind of a frayed rotator cuff. A lot of the times when we do surgery on people, we put the camera inside of the joint. So this is the head of the humerus. This is the bicep tendon, and we're inside of the joint looking up at the rotator cuff muscle. We're underneath it. And so a lot of times you'll see this frayed tissue, and that's what a partial rotator cuff tear looks like. Then there's bigger rotator cuff tears. See this? This is now a different view. Think of a bird's eye view looking down on here's the head and here's the socket. And this tissue right here is the rotator cuff. That tissue up there belongs all the way over here. So this is what a rotator cuff tear. A lot of the times you'll fall or whatever, and this tissue pulls off and goes back there. That's kind of the before picture, and then this is the after. What we do is take that tissue and pull it back down and repair it to this bone. And we do that with plastic screws and real strong suture material that's right here. So we can tie that tendon back down to the bone, and then the blood in the bone will help that tendon grow back into the bone and heal the rotator cuff tear. And there's just showing a picture of grabbing that tissue and putting it where it's supposed to go. And then here's another picture, just a small tear. See this little tear right here? This is looking at the top again. This is the before, and then this is the after. You can see where we put sutures in the tear and then stick it back down on the bone. And then there's plastic screws that are right here that help hold that suture material down to bone. So that's how we do rotator cuff repairs. Very common. And again, these are almost always done arthroscopically. Okay, so I always tell people I'm a certified biceps killer. The bicep tendon, which runs in your arm, is, this picture shows it better. We use this in the office all the time. So you see this little guy down here. It's hard to see, but here, this is the bicep tendon. And it runs in a groove in the front of your arm, then it goes and hooks into the socket, right? And its sole job in life is to cause pain and discomfort and drive people crazy. I'm convinced of that. And so a lot of shoulder issues, in my mind, revolve around the bicep tendon. But your bicep has two parts of it, one that hooks over here, and one that goes deep and hooks into your socket. People commonly rupture it up here. You'll see people walking around with a Popeye deformity, right? If you're on the beach, some of you may have this too, where people rupture their bicep and it moves down, and people get a Popeye deformity. The place I did my fellowship, this is what our fellowship director always told this story, took care of the Denver Broncos. Most of you know who John Elway is, right? So he was about to retire. He had a terrible bicep, what I call a slap tear. It's just where that bicep attaches to the socket here, it was torn. Very common. Baseball pitchers get it. Overhead athletes get it a lot. So he was about to retire because his shoulder was killing him. Well, he was in practice throwing one day, and boom, he ruptured his bicep and got this Popeye deformity. After that, he won 2 Super Bowls and said he hadn't thrown the football that hard since he was in high school. So the moral of the story is, it's the devil. Its sole job is to cause pain, and you don't need it. Studies show, strength-wise, that even if it does rupture and you get this, it has no effect on your strength long-term. And multiple studies have shown how big of a pain generator it is, but it's a very common tendon to injure. In all of the meetings that I go to, you'd be surprised at how much topic of discussion this little bicep tendon gets. People argue about it, and have argued about it in our meetings. People, talk about the bicep tendon, this little stinky, wimpy tendon we dedicate a lot of time to, but it causes a lot of pain. And this is just showing a picture of that labrum, the lining of the socket. It can get torn too and cause pain. These little things flipping out are just pieces of the labrum that act like hangnails. It's the best way to describe them. It's just that tissue, when it pinches, hurts. And so a lot of the times we'll clean that up at surgery as well. Again, there's my little devil picture of the bicep tendon. And this is a scope picture showing what that slap tear is. So here's your bicep tendon, here's your socket, and that's where it attaches. And you can see how you can pull it off. So every time you reach or move, that bicep pulls and that hurts. And so always one of the first order of business when I do surgery on somebody is addressing this bicep tendon, usually releasing it, just unhooking it from where it attaches right there and hooking it up. We can hook it up elsewhere with the screw. It's purely a cosmetic procedure, but just getting it detached helps a lot of people alleviate their pain. This is a picture I put on here of shoulder instability or shoulder dislocations. I tell people, visualize a golf ball sitting on a tee. That's what you think of a shoulder is when it's unstable. And that's what you can see where that golf ball is off the front edge of the tee. That's what a shoulder dislocation looks like. So that shoulder will move. It's not supposed to go off the tee. It's supposed to be sitting on the tee all the time. And so people that have shoulder instability, that head will move back. Most of the time people dislocate their shoulder out the front. And that's just showing what it looks like in surgery. When we put the scope in there, we can move that shoulder and dislocate it. And so, again, these are my 15, 20, 25-year-old patients, athletes usually, or just people that are born with loose tissue. They tend to be more prone to dislocating. And this is a picture of what bursitis. Remember I said that red inflammatory tissue. It's red, it's nasty, it's angry. This is what it looks like. Every shoulder that we scope, we go in there, that bursa is red, inflamed, and nasty. A lot of the times, you know, when we give people shots, I tell people it's like Visine, it gets the red out. This is what we're talking about. This is, the steroid goes in there and helps decrease the inflammation in here, but sometimes that doesn't work. And when we go in and remove it, this is what it looks like. It's just red, nasty, inflammatory tissue. Other things that can happen, fractures, right? People fall all the time. I think the number one injury I see around here is people walking their dog, hands down. It's the most common injury. It's crazy. I've seen the worst fractures from people walking their pets, walking their dogs. They're looking this way, the dog sees something, takes off, boom, knocks them down, fall, and then you can have bony injuries. So this is really common injury around here. These fractures, so that's the head of the humerus, and you can see all those little pieces, right? It's not what it's supposed to be. It's supposed to be one unit. So people fall, and your rotator cuff muscles are attached to all these pieces. And so, and here's a big fracture line here, right? And so there are different options on what to do, right? This injury, if this is a 25-year-old, I'm trying to fix it. If this is a 75-year-old, we're replacing the shoulder. So it depends on the age of the patient on what we do with it. And so, yeah, a lot of the times we can fix these fractures. All right, this is what it looks like when we fix them. We put these plate and screws and all that on there. So that, you know, this requires an incision where we open it up, take the fracture pieces, put them back together, and use this plate and screw to kind of hold on to it. Collarbone injuries, right? Clavicle fractures, you can see here, really common bike injury. People ride their bike, thrown off their bike, wreck, football, all kinds of trauma. And the pendulum swings on how to treat these a lot. Before, a lot of the times we treated these without surgery, and we still do. But when these things are shortened or they tent the skin, because there's not much under your collarbone right here. It's just skin only. There's not a lot of meat. So a lot of the times those fractures will poke on the skin, and so that's usually an indication to go in and put a plate and screws on there. So this is just showing collarbone fractures and then how we fix it with plates and screws. And this is another type of injury called an AC separation. So you may see people there, this AC joint is on the side of your shoulder right here. It's where your collarbone meets this bone called your acromion. And there are ligaments that help hold this in place, ligaments that help keep your collarbone down. So I see this commonly in football players. I see commonly anyone. People fall, usually they fall directly on their shoulder, on their side. And this part of their shoulder goes down, and what it'll do is it'll tear some ligaments right in here, and then it'll cause that collarbone to pop up. And so this is basically a shoulder sprain. You'll hear people with a shoulder sprain. But sometimes that collarbone will kick way up and we'll have to fix it. And we can do that different ways, arthroscopically. You can use plates. There's different ways to fix that. And there's different types of these separations. But this is a very common injury. A lot of times you'll see people walking around and have a little bump on their collarbone right here. If you notice, you're walking on the beach, and a lot of those people had old sprains of their shoulder, and they heal with a little bump on their shoulder. So that's a very common injury. And there's different grades of these, from just a mild sprain all the way to where the bone shoots backwards and side. There's all different ways you can injure this, but that's just, when you hear a shoulder sprain, this is usually what people are referring to, these little collarbone injuries. And then there's arthritis. So remember I showed you the shiny white cartilage. When that cartilage goes away, then you get bone rubbing on bone, and that's what's shown here. So we use the term arthritis very loosely. Any kind of damage to the cartilage, we term arthritis, whether it's a crack all the way to the cartilage is completely worn off and it's bone rubbing on bone, which is what this shows. So there's varying degrees of that. And so you can see this down here. There's a big bone spur right here. And And then you can see there's no joint space. These are things we look for on x-ray. Joint space narrowing, bone spurs, bone rubbing on bone. And so that's an arthritic shoulder. People tend to tolerate arthritis of the shoulder a little bit more than weight-bearing joints, right? You know, hips and knees, you're walking every day. When you walk, you put 3 to 5 times your body weight through your joints. With your shoulder, we don't walk on our hands, thank goodness. And so people tend to tolerate it more. And this is just a side view showing, you can see there's no joint space here and that bone rubbing on bone right there. This is my golf ball sitting on a golf tee analogy. You can see that now. The socket part is like a tee, the head's like a golf ball. And so, then the treatment for this, we always start with injections and therapy and things like that, but when that stuff doesn't work, the overall treatment is a shoulder replacement. And this is a standard shoulder replacement. So there's standard shoulder replacements, and then there's what's called a reverse shoulder replacement. The difference being that is your rotator cuff muscles. You need all your rotator cuff muscles to be intact and working to get a standard shoulder replacement, right? Remember I told you that 75-year-old that had no rotator cuff attached to their shoulder and came in and had full motion and great strength? Why do they have that motion? It's because their other muscle, the deltoid, took over, right? And so that's the theory behind a reverse shoulder replacement, which is a picture of this. And the reason it's called a reverse is because if you notice, the ball is on the socket side and the socket's on the ball side. Versus here, ball's here, socket's here, right? That's the reason it's called a reverse. It just changes that. And the theory behind this is that ball pushes everything this way to help your deltoid move your shoulder. That's the theory behind the difference between a standard shoulder replacement and a reverse. You're trying to push things out further to help your deltoid act as a lever arm to help give you shoulder motion. This one, your rotator cuff muscles are already there, so you're not really worried about that. You're using those muscles to help you move. And so that fracture picture I showed you earlier that was in a bunch of pieces, that's why we end up replacing it now, because you don't need your rotator cuff. We just go straight to this replacement in the appropriately aged patient. So that's the difference between a standard shoulder replacement and a reverse shoulder replacement. I get that question commonly in the office. And that's the difference, is whether your rotator cuff works or it doesn't work, or it's there or not. That's the determining factor on which one you get. They're both a replacement, but just different theories on helping you. Very predictable for pain relief. The reverses aren't as predictable for getting motion back, although people get pretty good motion with it.